Commissioner Gibson.
Would you bow your heads with me? Gracious and eternal God, Father, how grateful we are that your hand rests upon us each and every day. We thank you for watching over our community and for guiding those who work as a part of our health department. And we ask for your guidance this evening as we discuss the business of this community. Lead us, guide us, and direct us so that all decisions that we make are made in the best interest of our citizens. For it is in your name we pray. Amen.
Amen. We have our agenda in front of you. Will we have a motion to adopt the agenda? If it's any discussion, need a second. So moved. The next item on the agenda is approval of the minutes. They weren't in the packet, but they should be before you. So if you want to take a minute and review the minutes.
Second.
We have a motion and a second to approve the minutes. The motion is carried. Next on the agenda, we have the public forum. I don't believe we have anybody signed up, so we'll move on. Next on the agenda, we have special recognition of healthcare graduates. Okay. We have 4, I believe they're here, or the parents are here. We want to present you with a certificate. These certificates are on behalf of the Board of Health for your achievement in graduating. We believe we should recognize all graduates that graduate from any college, but we want to recognize graduates that have a position or will apply for a position on the board. The first certificate goes to Andresia Harrington. She graduated in registered nursing. Congratulations. Next, we have Felicia McDade, also graduated from registered nursing. Next, we have Dr. Annalisa Soroka. Hi, Doctor.
I'm not the doctor, I'm the mom.
Doctor.
Awesome.
And last, we have Dr. Bianca Baldwin. You will get her certificate for her. And she's on graduate this. This is something the board is gonna do in June and December of each year for graduates each half year. And this is the first time, so this is the first go round, and I was excited.
And I'll just add that I work for Scotland Memorial
Excited.
Hospital and I recruit. So any, health related new grads. can
Okay.
call and I'll-
Look, she
Sorry, dear. I work in the emergency room, so I just finished my bachelor's.
all right.
Good.
Congratulations. All right. Next on the agenda is the administrative reports. We'll have our first fiscal update by Tim Martin.
Good evening. Ooh, that is loud. This is the financial update for the Health Department as of May 31st, 2023. As of May 31st, 2023, we should be 92% used on our budget. As you can see at the bottom, we are at 79.1% spent of our budget. So we are currently considerably under budget. With the hard work of our staff, we constantly try our best to keep the finances low so we can, while still providing services for the community. Does anybody have any questions?
What are some of the reasons that you accredit us for being so under budget?
A couple of things this year have been the fact that we've had lapsed salary. I think this year is probably, and I'm sure Sharon can probably speak, this year's probably been the most we've had open positions in a long time. So just transitioning staff, and that causes lapsed salary, and then that causes we're not paying anybody, leaves the money in the pot. So, and plus we are still getting COVID dollars for several grants. And so for example, if our nursing is working in COVID, getting the vaccine, or our director of nursing is doing contact tracing or any of those things, that salary is offset by COVID funds. So therefore there's money. Yes, sir.
Thank you.
Any other questions? Okay, the next slide is revenue collections. Once again, it should be at 92%. We're currently at 70%. We're a little bit under budget as far as collections go. Once again, we talked about the numbers being down in the clinic. So it's come up a little bit from what I gave a couple of months ago. So we are doing a little bit better and collecting money, which I'll talk about in just a few minutes when I recognize my wonderful, wonderful staff that's behind me. Any questions?
I don't want to ask all the questions.
You're
but
fine.
I do have a question.
Please, please.
It's probably not necessarily for you, but more probably Donna. I think I've heard repeatedly that our numbers are down in the clinic. What are we doing to try and lift those numbers? I would imagine if those numbers stay down for too long, we find ourselves in a quagmire.
I will let
I know that's not your question,
Yes,
so
sir.
I'll give it to whoever it belongs to.
Donna or man.
And COVID had an impact because public health had to slow our services while we had our standard services we always provide, like immunizations. We never stopped doing that, but there were some services because we had other things going on with COVID. So since Amanda's been there, we're working on outreach. We've been out to the college to try to recruit new patients for our family planning services. Just trying to boost our numbers with our pregnancy clinic, and hopefully having some meetings with the docs about that. And our immunization numbers usually are pretty good, but there's some outreach things that we do, but we haven't went on the street yet with a spinning sign, but that's an option, I guess. And we are working on it. That is something that Amanda has been focusing on since she's been there to try to get her numbers back up.
And I only bring it up because, and I don't know, I know I don't really have to say this, but if we don't have patients, we don't have a business.
Well, public health was not created to make money anyway. It was created by the government, for the government, to take care of people who didn't have the ability
Oh,
to
yeah,
pay.
certainly.
That we do generate some money is a benefit, and it obviously, the health department is one of the few departments in the county that does generate money. But again, those services, if everything was wiped out, we still have to provide basic services whether we generate money or not. I mean, yeah, it's a perk, and we do want to make money.
That's right.
But again, it was not created for that.
Understood.
And I will state, as far as especially some of these grants go, we do get funding to make up for these people who come in the door who do not have the ability to pay or get a reduction in pay or who are confidential. So those grants from family planning you'll see and from maternity cover those patients as well. So we are just supposed to, and our general statute says we will make every reasonable effort to collect any type of revenue we can. So even to the fact where we can go after your tax dollars, your North Carolina tax dollars, I should say, when you owe the money. So any other questions? And the next slide is just to show you a little bit about our COVID monies. There are only three that will be moving forward, the 361, which is a school grant, and the 620, which is also a school grant. I'm sorry, Nicole, but we're going to lose. Those are gone as of May 31st. We do not have those grants any longer. We do have the ELC grant, which is one of the very first grants we got, which was for contact tracing and mask and hand sanitizer and temperature stations, anything else that we needed for that. And then 716, which is solely based on vaccinations, was giving out the vaccinations. And then we have the CD pandemic recovery, which has helped with some of our communicable disease that's gone under the radar since we were doing COVID, and also helps with our HIV case management. And you'll see at the bottom that 543, the mobile medical unit and accessories, $120,000. The CD emergency response vehicle, Miss Amanda was great. She can talk about that if she'd like.
That's part of our COVID funding, and I sent a request in to the program director at the state and got $60,000 approved for us to get a minivan for communicable disease outreach. So that's been approved, but of course we can't spend any of it till after July 1. So, but after July 1, we'll be pursuing getting our minivan.
What kind of wording did you use to get that? You had to use,
It was very
Like-
good. It was very good. It was really good wording.
you know,
I
similar.
can send you a
Okay.
copy of the letter.
Okay.
And 716, which is the vaccine grant, we do have a generator. It was just installed last week. It is a wireless detected generator, so we can see what's going on when the generator goes on and off via our cell phones and via computers. If you came in this way, you might have looked next door and saw the walkway that is now over the health department. That was completed last week as well, but has not yet been paid for, but it would pay for this coming year. And then also renovations and improvements to our general clinic where we actually give out our COVID vaccine. They're remodeling that area as well. Any questions?
Yes. It could be because I can't hear you, but.
Yes, sir.
What is a vaccine generator?
Basically, it's just a generator. It's a Generac generator that's hooked to our vaccine freezers and vaccine refrigerators. So if the power goes out, it kicks on, so we don't lose thousands of dollars worth of vaccines. Any other questions? Okay, really quickly, I'll just go through next year's budget. We just talked a little bit about the COVID funding that's going to roll over to be used next year. And then we also talked about the vehicle that Miss Amanda discussed as well. Anybody have any questions? All right, thank you so much.
Thank you, Tim. Before we go to the next item, any visitors that are here, if you want to leave, you don't have to stay for the next portion of the meeting, but you're welcome to stay because it's public. If you want to stay for the whole thing. Okay. Thank you. Thank you. Next, we'll have our monthly activity summary. Miss Samantha.
Okay, this is the bar chart that shows the monthly activities over the last 3 years. And as you see, previous years, we had a whole lot more activities going than we do right now. WIC services is starting to pick back up because the COVID flexibilities are gone. So now they're coming in, or they're going to have to start July 1 coming into the clinic. So you see it's moving up, but we still got a long way to go on some areas. I just wanted to touch a few highlights from my April and May Health Directors Report. I attended the budget meeting with the county manager before he left to discuss the 22-24 budget. Tim and I went to that. We funded the school health resource library with the school health liaison funds. So the books and pamphlets were presented to the school district. I attended the state health directors meeting in conjunction with the public health law training, which myself and Donna and our environmental health supervisor, Valentino, attended. We were closed on April 5th for Staff Development Day, where we worked on public health ethics and work culture training. And I think everyone pretty much enjoyed the team building exercises that we had. We had a community health fair on April 29th, and even though we had a rain shower and had to move everything inside, we had 25 vendors and over 50 participants to come. And April was the month that Tim and I had to do the agreement addendums. So they were reviewed and program budgets were completed and signed and sent back to the state. In May, I discussed Teen Pregnancy Prevention Month and Nurses Week at the Board of Commissioners meeting on May 1st. We had some funding in last year's budget for a vehicle. So I was able to obtain quotes for a new vehicle, and we purchased a 2021 Nissan Kicks from Scotland Motors to be used for community events and out-of-town training for the staff. We celebrated Nurses Week, and there's a picture of 2 of our nurses up there. We had cake and certificates of appreciation for our nurses. But what I'm most proud of is I had 2 teenagers to come by my office one Friday afternoon, Holly Covington and Savannah Chavis. They're rising 11th graders at the high school. And they asked me, could they partner with the health department to do a teen pregnancy prevention initiative for our school project for next year. So we've been working on that, myself and Jana Blue, our health educator, with these 2 sweet little ladies. And they are going to be called ambassadors for the teen pregnancy prevention program. And they've already started work. We had strikeout bowling, strikeout teen pregnancy, and they brought several of their peers to that. And they're really excited. They're part of the SHAC team, the School Health Advisory Council. So I'm really excited about working with them the next year and getting the word out to our teenagers on the services that we offer. At my health director's training at the state, we had someone to present Diabetes Smart North Carolina program. And I'm interested in starting that program at the health department. Diabetes is one of the top 5 causes of death in Scotland County. Diabetes Smart program provides diabetes education that's reimbursable by Medicare and Medicaid and private insurance. The program is proven to improve hemoglobin A1C, control blood pressure and lipids, increase rates of medication adherence, reduce complications, and increase healthier lifestyle behaviors. This program falls up under DHHS umbrella. We would pay $250 a year to the Diabetes Smart program. With that $250 a year, they will help us get accredited, and they'll help us with our billing issues as far as Medicare and Medicaid. They will also provide the diabetes curriculum for us to offer. I've already started the initial paperwork with them, and they said it would probably take 6 to 8 months to get us accredited in order to bill. But I wanted to present that to the board for your approval and see how you feel about it. I put a SurveyMonkey survey on our Facebook page. And one of the questions on the survey was, would you come to the health department for diabetes education? And it was 100% yes. So I think this would be, as you mentioned earlier about our numbers, this is another way of increasing some of our numbers at the health department and increasing some more funding.
Is this something we need to adopt? Right.
I would
Okay.
like you to.
So we need a motion to adopt the Diabetes Smart NC program.
For us to approve to move forward.
The health department will pay $250 a year, and they'll help with accreditation. I'm all for that. That's not bad.
All for it.
Yeah. Need a second. Okay. All in favor?
What are
Any
we
opposed?
voting on? I can't hear half what you say.
Oh, he made a motion to adopt the Diabetes Smart North Carolina, with the $250,
A year.
application fee for the accreditation. And so the board made a motion that that's what we will vote on for the health department to adopt it, to bring it here.
Oh, okay, I'm for it.
It's okay.
All right, all in favor, say aye. Any opposed, like sign? The motion is carried. All right.
Okay, I'm
Okay,
excited.
girl.
And Donna, did you want to go over the clinical updates?
Wow. I only ended up on one slide.
Kind of touch on some of the
Listen.
highlights anyway.
The one thing I would like to mention is one of our newest public health nurses finished her credentialing, the first class of public health nurse credentialing through the state. So that's her name's Joy Hawkins. So that is one thing that we're very proud of, that she was in.
Ms. Joy, would you stand up?
This is Miss Joy. And prior to this program, the new public health nurses were required to take, if they didn't have a BSN, were required to take a principles and practices of public health nursing. And so that has been sunsetted, and they're doing the credentialing now. And actually, it'll be all public health nurses, regardless of BSN or however long you've been working. Years of experience doesn't matter. So all of them, there'll be a credentialing behind the name now. Other than that, you guys have it in your packet. So if you have any questions, let me know.
Thank you. And social workers, Miss Betsy's not here. One thing I'll point out with the social work staff is they attended car seat training, the proper installation on car seats, so they can provide to the community if anyone wants to know how to properly install your car seat. They're now certified in that. And management support participated in a lot of outreach the last few months. And Tim, you want to do departmental focus?
Good evening again. I know y'all see me every other month, so I do want to give you kind of a feel of kind of what goes on in our department. We are fiscal management, not physical management. We don't manage physicals. I get that a lot. So people call and say, do you manage physical? We actually handle all the money that comes in and out of the agency. Between me, myself, and the health director, we basically budget the health department, make the budget for the health department, and recommend what we need to the county manager and to the board of commissioners based on what our programs desire and need. For example, our programs, instead of one health department budget, there's probably about 12 or 13 budgets inside of that one budget. Each AA has its own budget. So when we say family planning has its own budget. Maternal health has its own budget. And we have wonderful program managers. One of them's here tonight, Carlotta. She does our maternity program budget for us. But we all work together to get that program budget together, how to spend the state's money that they give us as far as grants. Once that's complete, we actually monitor and maintain. Nothing is bought without Miss Amanda's approval. And then I code it, and then we go on from there. So I'm going to stop and talk about me, and I'm going to talk about my staff. They don't want to get up and talk tonight. I asked them if they want to. Last chance. Okay. Y'all want to come up here? No? Y'all rather stay there?
Stand up.
Let's just stand up for me. Just stand up for me.
Stand up.
I'll let you introduce yourself. Okay. Antoinette is our newest in our department. She's been here 4 months, 5 months, 6 months. See, I've gone past me. 6 months, time flies, right? She is our billing and accounts receivable. In other words, people who do not pay, she turns around and sends them collection letters, and she also helps work denials on insurances. Her and Dora, who we'll talk about, so I just kind of split things up. One does Medicare and insurance, the other does Medicaid. So it's just not so much on one person. So thank you, Antoinette. She does a wonderful job. So next I have Dora. There's Dora. Dora is actually our medical biller. Everything that goes on at the back that they do, she actually bills the insurance companies for. So she has a wonderful job of bringing the money in and making sure that it's coded correctly so that we can get reimbursed. She also assists Antoinette in doing some of the denials, and she's getting more and more duties every day that we're adding to. And same thing with Antoinette as time goes on, because a lot of duties were on me where we were without staff for a while. So thank you, Doris. She does a wonderful job. And last but not least is Jordan Locklear. She is our accounts payable and payroll. So she's the important person to make sure that everybody in the health department gets paid, including the Board of Health. So she does handles our executive time and our time off assistance. She pays the bills. She gets everything together for the checks to be written for all the services that we have. We also in fiscal management have the fleet of vehicles that are out here. We do manage those fleet of vehicles and maintain those fleet of vehicles. We also maintain the office supplies for the workers to use. Trying to make sure I remember everything. We also, actually, I do no longer do inventory. That is now Christine's job. Inventory, but we we also do IT inventory for the IT equipment and work orders when stuff doesn't work. We call IT, and also public buildings, which that's gone to Christine now too. So if something doorknob falls off, we take care of that and send that out. Any questions? I would ask them to stand again for me if you don't mind. And I'd like to give them a hand for all their hard work. I cannot do half anything that I do without their help and their assistance. So I appreciate them so much. Anybody have any questions about fiscal management department?
Is your department fully staffed right now?
Yes, sir. And I will gladly say, and that we are no longer behind on billing. We are up to date on billing. And so for the past 3 or 4 months, we are good to go. So we've found a way to get everything done actually the next day, right? So it's.
And they're constantly learning new things. I think they had some training today where they learned one of the private insurance companies to manage care with United Healthcare.
Mhm.
They came last week, well, one of the representatives did, and they provided some more training today for them. And I understand y'all sent in some bills and got it paid that were denied. I'm very proud of Tim's staff. He's got a really good group now, and they work really good together.
Thank you.
Tim,
I'm just gonna stay right here because the next part's there too.
2023-2024
Oh,
fee
I'm-
schedule.
You're fine. There's really not a slide for this. You had this in your packet. Accreditation requires that I give you the new fee schedule for the upcoming year and that it is approved by the Board of Health. I hope you've had a chance to look at it and see. Once again, our fees are set up where whatever it costs the nurse or the provider to do down to the very last tissue or cotton ball or whatever they use, we use that in cost to make our fees according to the state. Any questions on that fee schedule? If not, we'll just need a motion to approve it for FY24.
I do have a question.
Yes, sir.
And somebody else, please ask some questions so I don't sound like I'm in a pain. When I looked at it, I'm assuming everything in red is a change.
I apologize. No, everything in red is not a change. That's the actual fee. And I don't have it in front of me. I'm sorry. Yeah, that is the actual fee. I apologize. The red is the actual fee that it is for the FY24.
Gotcha.
Okay, red's the actual fee that you're proposing or the actual fee that's in? force?
Proposed.
Huh?
Proposed. This is proposed.
Okay. Go ahead before I object.
Oh,
Okay. So we have a motion?
Not yet.
Not yet. We'll discuss it. Okay.
I guess for me in the future,
yes, sir.
it would help for me to know what these fees are
Okay.
and then what they're being changed to. And an example, I'll say the problem focused exam is now $88. If I get a complaint later that it went up from 20 to 88, I can't, because I don't know what it was.
So-
So in the
Yes.
future, if you can do that for us,
Yes, sir.
that way we can tell which ones have changed and what they've changed.
Yes, sir. I totally understand. The only thing that changed on this fee schedule would be your immunizations that you'll see for adults and for children, and then some of the labs to go stuff that's at the very back. And I apologize. I'll make that clear next time. My apologies.
Okay. How do these fees stand up to most of the insurances that we're billing, and are they approximately equal to what reimbursement is? Are they slightly above? Are they a good bit above?
Most of the time we're above, and the reason we're above is because if you charge $49 and they're going to give you $50, you don't want to charge 49, you want to charge 50.
Believe me, I'm really
So yes.
aware of that.
So,
I just wanted to make sure we were charging at or above the
correct.
usual, so that we're reimbursed at the appropriate level
Yes, sir.
and not underbilling or overbilling excessively. You want to be right about where
Yes, sir.
they standardly are. And I do agree with Commissioner here about that would be great if we could see if there were any changes.
Yes, sir. My apologies. I'll make sure that happens next
Sure, as
time.
long as you folks have done this, you're in the appropriate categories. And for what I know, it looks very appropriate for the 1 through 5 in both new and established.
Mhm. Now, I will say these fees don't change very often due to the fact that Medicaid, Medicaid's our biggest provider. So their reimbursement rate kind of goes a little ways, pretty hefty ways with what our fee is going to be. I will tell you that Medicaid has paid us $8.04 for pregnancy tests for 10 years. So their fees haven't changed, and our fees probably haven't changed a whole lot. The only fee change that we have most of the time will be those immunizations, and those are private immunizations that we give out to people with insurance, and for children who have insurance, and those fluctuate. The price of immunizations and vaccine fluctuates quarter by quarter. So we actually take the price that is actually through the vaccine and we round it up to the next dollar and times it by 5%. So we make it less some money. And plus we have an admin fee of $25 for giving that vaccine as well. And if you guys would like me to go into more detail about the fee schedule and all that stuff, I'll be more than happy to do so at some point in
I
time.
would say on the labs to go fee schedule, if you look at those, they're much lower than what you would pay at your private doctor. But these are paid upfront. To get these labs done, it's private pay.
And I'll actually get y'all that information of what changed and I'll get that to you guys. Is that okay?
Sounds good.
All right.
All these done by a prescription by a provider.
Have to be, I'll let Donna answer that.
The labs to go.
The labs
to go.
Are they all done only by?
The prescription, some of them do. Order physician.
Could you maybe do an analysis of this and tell us exactly which ones are going up and which ones are not?
Yes, sir.
Let us talk
Yes, sir.
next week.
Yes, sir. I will have that next time for you. My apologies. I just have to have it approved before July 1. And it's already went to the commissioners and I think they already approved it in their budget thing and their budget announced their budget package as well. So
We table this until the next meeting.
We won't have another meeting before July. We won't have another
I think we
meeting.
can. It's 2 months and they need to be able to file this.
Is what?
It'll be 2 months and they need to have this upgraded to be able to file, I
Mhm.
believe. Am I correct?
By July 1.
July 1.
Jason already has this fee schedule in the budget. I had to send it to him beforehand. Since we meet every 2 months, there's no way for me to get that information ahead of time.
But in general, it's close to what it was
Mhm.
before.
Yes, sir. Yes, sir. Once again, the only thing that changed was those few that I just spoke of a while ago.
Mr. Ryder, did you hear that? The fees are approximately the same as last year. It's very gone up.
And which ones have gone up?
The vaccines for the adults, you'll see that those went up, and actually the labs to go actually went down on some of those. So,
Well, I don't know. We're charging too much as it is, I think, but
I don't know how this.
Unfortunately, I don't think we really have a choice but
Yes.
to pass it.
Yeah.
But I just think in the future, we learn and do better.
Yes, sir.
So I offer a motion that we pass it fiscal year
Can we have a
24 fee
motion?
schedule.
We have a second?
I second it.
Okay, any more discussion? All in favor say aye. Any opposed, like sign?
But we will have some conversation with Mr. Wayland next.
Yes. I will make sure to get all that, what's changed and what's not changed. And if you have any ideas of what these things are or what they might mean, I know Dr. Boland knows kind of what the 99211 and 91212 and all stuff is. But maybe if you want a little more detail, we can go into that as well. So,
All right, the ayes have it and the motion is carried for the fee schedule.
thank you. I apologize. I will get it for you next week.
Next on the agenda is the HIV in PrEP. Donna? Okay.
I don't do real well standing still, so, and I don't know how this mic will do if I start moving around, so I'll try to stand still, and I'm gonna try not to go down a rabbit hole. HIV, first of all, I'm Donna Page. I'm the Director of Nursing, but I am also a communicable disease nurse, and I oversee our HIV clinic, our communicable disease clinic, and our STD clinic. And so back in 2019, it was June 16th, 2019, about half of you were on the board then and half of you were not. I came before the board to discuss PrEP, which is pre-exposure prophylaxis for HIV. So we wanted to start a clinic at the health department for PrEP because of our numbers in our county and HIV are so high. And it was passed by the board then. But because there are so many new faces, I felt like I needed to do this again. So you guys, and it'll also, as part of starting a new program at the health department, we need the board's blessing and approval to start that program. It'll also go before the commissioners just for their pleasure, but you guys are the ones who decide whether we are able to move forward with having this PrEP program at the health department. So our objectives, and I gave you a piece of paper that have these written on it. So we'll talk about PrEP, and for those of you who don't know what it is, we will learn that. And we'll discuss the initiatives for ending the HIV epidemic in America and how PrEP can impact that ending the epidemic. And we'll also discuss our county, federal, state, regional, and county HIV rates. And then we'll identify and discuss local interventions that could impact ending the HIV epidemic in America and reduce HIV rates in our county. So I'm going over here. Got a quick video for those who don't know what PrEP is. Really quick video. I had this working earlier. I'll tell you. I'll let you check all of it. So PrEP is pre-exposure prophylaxis, and it is a method for preventing, it's medication that people who are at high risk for HIV or being exposed to HIV take, and it prevents HIV transmission. Someone who's HIV positive obviously would not take this medicine. So it is a prescription, and it is closely monitored. A patient who comes into a PrEP clinic has to have initial labs. They have to have labs every 3 months for the first year and then yearly after that. So it is a way to prevent HIV. So to talk about it, we've got to go back in time a little bit here, back to 2019. And back in March of 2019, President Trump had $290 million to spend on ending the HIV epidemic by 2030. And so what they did with that money, there were 4 points in that plan: diagnose, treat it, protect people who are at risk. So PrEP, that is protecting people who are at risk. and of course, respond to clusters and new cases. So that was President Trump's plan. And at that point, with that $291 million, they looked at hotspots in the United States. And so this map shows the geographic hotspots. Mecklenburg County got a big chunk of that money. That was the only place, the only city in North Carolina that got any of the $291 million. The states that are completely blue, the whole state is a hotspot. So guess who we border with? South Carolina is a hotspot. So they are our neighbors. There are a couple of federal strategies that have been initiated to lead to ending HIV. And the first one was 2010 to 2021. Now, PrEP did not come out as a prescription prevention medicine until 2015. So about halfway through this first strategy was when PrEP came up. And then in 2022 to 2025, where we're at now, it is a huge piece of the ending the HIV epidemic and preventing HIV transmission. So we call it the strategy. It's the federal. It's the United States will be a place where new HIV infections are prevented. Every person knows their status, and every person with HIV has high quality care and treatment and lives free from stigma and discrimination, and can achieve their full potential for health and well-being across the lifespan. So this includes all people, regardless of age, sex, gender, identity, sexual orientation, race, ethnicity, religion, disability, geographic location, or socioeconomic status. So just remember that that everyone knows their status, because that's going to come up later when I talk a little bit about why it's so prevalent where we are, and also the stigma and discrimination issue that comes along with HIV. And these are all the agencies and committees and departments that have a piece of the pie when it comes to the strategy. So there's some good news here. Viral suppression. Now, with viral suppression, that means when someone who is HIV positive is suppressed, they cannot transmit HIV to another person. In 2010, 1 in 4. So only 25% of people who were HIV positive were suppressed. Now we're over half. That was in 2019. Again, we're traveling through time. We'll come up to date here soon. New diagnoses, they have declined by 14.3% in 9 years. Deaths have declined by 7.6%. Now, I was an EMT with Scotland County EMS in the mid-'80s. And back in the mid-'80s, 130,000 new HIV infections. Now, in 2019, 34,800. The 80s was a scary time. I don't know how many of you were alive and in that, but it was scary. I seen people who had AIDS. I seen people die with AIDS. There are a lot of people, and you'll see the population that is becoming HIV positive now, that don't realize that, yes, HIV, you can treat it, you can live a healthy life, but it is a life sentence. It is a ever-changing part of someone's life once they get that diagnosis. It's a daily struggle. There's a stigma with it, and it's not just I take a pill and everything's better. If they don't take their medicine, if they don't do well with the medicine's expensive. You have to go to doctor's appointments. It's very life-changing. And to see someone die with AIDS, it is not. I rode in the back of an ambulance with quite a few of those. So again, I could go down a rabbit hole there. So disparities still persist. Effective treatment prevention are not reaching the people who could benefit the most. The Black and Latino communities are disproportionately affected by HIV compared to other racial and ethnic groups. This table right here, this was from 2019. The percentage of the Black population living with HIV was 40.3%, but they only make up 13.4% of the population. Hispanics, the same, not as bad, but 24% living with it, 18% on part of the population. Look at the white population, 28% had it, 60% of the population. So now we're going to drill down a little bit closer. We're going to get into regional areas. So when you look at regional areas in our country, look at the South. The South has 51% of all new HIV diagnoses in 2020. That, to me, is amazing and astounding and crazy. And in the South, fewer people are aware of their HIV infection than any other region in the country. Fewer people who are living with it receive timely medical care and treatment. The mortality remains 3 times higher than in some other states. and more people are missing the opportunity to avoid transmitting it because they don't have access to PrEP. And the factors why. Why is it the South? Why does this happen here? So you look at socioeconomic conditions, high unemployment rates, high poverty rates. Scotland County has one of the highest unemployment poverty rates in the state. Barriers to care. They don't have insurance. Half of all Americans in the South live without insurance. Transportation, longer travel times, rural areas. They just don't have a way to get where they need to be, especially if the clinic's somewhere over in Moore County. And that doesn't sound like far when you have a car that you drive every day. But for some people, that's a lot. They have to pay for gas to get there. Limited access to prevention and treatment services. And then we go back to the cultural factors, homophobia. We're in the Bible Belt. Homophobia, transphobia, stigmas related to sexual orientation, substance abuse disorder, and poverty. So stigma is a huge thing with HIV, and it keeps people from getting into care and staying in care. And here is a map of the South from 2020, and all the dark areas are where the higher rates of HIV are. As you can see, as it goes west and north, gets lighter, the colors change. But look at little Scotland County over there, right there on the border. We're dark red. So here we go again. Again, we're still in 2020. I'm going to drill down a little bit. 30,630 new HIV cases in the United States. 51.1 of those were in the South. And of those in the South, 6.9 were in North Carolina. And of those in North Carolina, Scotland County was 1% of the numbers. Now, 11 doesn't sound like a lot, but when you only have a population of 34,000, that's a lot. And the prevalence, which means these are the people who are living with it. And so 3/4 of the people are male, but women get HIV too. And then you look at the racial and ethnicity, 52% are Black, 17%, and the 24% white. And then you're looking at the new HIV diagnosis, sort of the same demographic. You see mostly males, some females, mostly in the Black population, over half in the Black population. And then this is what is striking to me, and this is where I was talking to you about age. The blue line is the people who are living with HIV. So, and you go to the right, it's the older population. So there's more people in the older population living with HIV, but when you look at the new HIV diagnoses, at the 13 to 24 range, 57% of new HIV cases are in that age range. That's huge. I mean, that's huge. And it's just going to increase. And this population, and this is in the South, this is not in the country, this is the South. And this is a table from one of our communicable disease STD summaries. Scotland was number 2. And the 2019 to 2021 average rate in the state for newly diagnosed HIV rates. So we were at 28% or 28, and the state is 14.5. So we doubled the state rate for our new HIV cases. And then these are the ones who have AIDS or stage 3. We were number 8 in the state for that at 11.7, and the state rate is 5.8. So we sort of doubled that one also. So our county in 2019 was 12 new HIV AIDS cases, 2020, 11, 2021, 11. So we remain at 12, 11, 11. That's again, because of our size, it makes a big difference. Now I compared us to some counties, our border counties, and these are cases per 100,000, 459 cases in Scotland County. Now look at Mecklenburg, how huge Mecklenburg, it was a hot spot. It's 657 per one. We're not that far off from Mecklenburg, and they're huge. Cumberland, we're really close to them, and I would venture to say their population quadruples ours, if I had to say. I don't know. I have not done that. So anyway, it's just that is not a good rate. 459, yeah. And so back earlier in the year, our health director and Kathy spoke with you guys about health rankings, and there were some questions about it. And some people said, well, what can we do? And the commissioners heard about this. So what I did was went into the health rankings and I pulled the 4 counties, our border counties. And this is how we compared for sexually transmitted infections through our board with our border counties. And so we were at 982.1. We were above Robeson County, Hope County, and Moore County. Now, Robeson was really close, but when you look at Robeson and Scotland, you might as well include us all in one big pot because, and as same as South Carolina, because even during the COVID pandemic, the hospital was inundated with people from these counties. So what's theirs is ours, and what's ours is theirs at this point. So yeah, now and then here we are in 2022, and we had 12 new cases of HIV and AIDS again. So we're up to speed on that. So what are we doing? So we do HIV testing at the health department, and health department is free, and we do it 5 days a week, and it is a scheduled service. We do have an HIV clinic, and we partner with Robeson County Health Department through their Dogwood program with Ryan White funds, and we have about 41 people in our HIV clinic. And we do have an HIV care manager, which helps with retention and care, because when somebody's HIV positive, you don't want them to be out of care. You want them to stay in care, stay on their meds, which helps reduce new cases. We do have an HIV care manager that follows our HIV patients. So what can we do more of? What do we need to do? So PrEP's for everyone, and we need it now. And we need to prevent new infections, and we need to protect our vulnerable populations. And we have a huge vulnerable population in Scotland County. And that is so why do we need it? We're a southern state full of poverty. We're rural. We're between 2 hot spots, South Carolina, Mecklenburg. High risk underserved populations. We have limited providers, and we have high HIV STD rates. And now let's talk a little bit about PrEP. The PrEP to need ratio means that it indicates that the lower it is, the more unmet the need. So when you look at this PrEP to need ratio from 2020 in our southern region, females, the average is 8.96. Females using PrEP was at 4.87, which is very low. The Black population, 3.72. And then look down below, it's 5.55 in that 13 to 24 range. So PrEP is not being used in the South like it should be. It's very underused. PrEP stats. Black people represent 14% of PrEP users, but 42% of HIV diagnoses, new HIV diagnoses, as well as Hispanics and Latinos, 17% of PrEP users, but 27% of new HIV diagnoses. And among all PrEP users in the U.S., 92% were male and only 8% were female, despite the fact that women comprised 18% of new HIV diagnoses. Teenagers and young adults had the greatest unmet need for PrEP among all age groups, with theirs being at 6, the PNR being at 6, and they account for 20% of new HIV diagnoses, and that is in the country, but only 13% are using PrEP. And in the South, Black people made up 52% of new HIV diagnoses, only 21% are using PrEP. Now, so where do we go from here? So as part of getting this program on its feet, again, what we're trying to do in 2019, and then COVID happened and that knocked us down. Part of this is we have to do a community survey, which is out there on this sheet I gave you for objectives. There is a scan code on there that you can go in and do the survey yourself. The video I was going to show you was actually on that survey that you can look at and learn about PrEP. Again, it's a real quick video, but you can go to CDC and learn lots more about PrEP. We do have to fund this program, and BJ, when you were talking about about money, this has been one of the sticking points that we just could not overcome, because there's so many uninsured people in this county, and they do have to have all these labs to make sure they're healthy enough to get these meds. So, but $80 is what would cost for the labs for 1 year. $80, but that is hard for some people to get their hands on. And then $30 yearly after the first year. Now, I will tell you this, I've been following the federal budget, and I don't know, I haven't looked in the last week or so, but there is some more money for PrEP funding, and I'm hoping It is my hope that when that money comes out, that we will get an agreement addenda like we do with our other clinics, that they will give us some money to fund a PrEP program. I've reached out to other counties to see how they were doing it. Of course, we can bill insurance if someone comes in. Most insurances cover PrEP programs and PrEP meds, and the meds are crazy expensive. But the pharmaceutical companies actually have programs that when people can't afford it, they can get these meds. They just have to go in there, and that's part of what we would do is help them get hands on meds after we get them set up to do the PrEP. We do have again, I mentioned the care management position is funded to the end of next year through one of our COVID monies. After that, it's a part-time position. So you might want to put a pin in that, because we'll probably be coming back to talk about that next year. Because we can't lose that position for our HIV patients. And if this program gets off the ground and does what I think it will to help the people in this community, we're going to need that care management position for guidance and help for these patients. Of course, clinical policies, they're easy. Staff will need some training, and then our little community survey. And I will finish by this quote from Dr. Robin Fanfare, HIV Division Director of CDC. Overall, declines in HIV incidence and increases in diagnosis and entry into care suggest that the expanded reach of HIV testing, PrEP, and treatment efforts have been effective. We have the tools to end the HIV epidemic in the U.S., but our nation will not succeed until they are brought to full scale and equitably reach the people who need them to stay healthy. To achieve our national goal of ending HIV in the United States, we must increase investments in proven HIV prevention programs, expand HIV testing, grow and diversify the sites providing HIV services, and center equity in every aspect of our work. And I'll also say this: National HIV Testing Day is the 27th, which is next Tuesday. We always have a testing day at the health department. We put signs out at the intersection, and we do testing. And we, for the first so many that come in to get tested, we give a gift card. But we're also partnering with Walmart and the Elton John Foundation this year. So after we do our testing here, we're going over to Walmart from 2 to 6 and set up there. And I'm hoping that there's some grant money in it for us. I don't know how much it'll be. So any money that we get from Walmart is going to go toward hopefully funding some of the lab costs for the patients for the PrEP program. So the pharmacy manager said he's going to give us a big check. I don't know if he meant big this way or money big. So we'll see. But we will be there on HIV testing day to partner with the Elton John Foundation and Walmart to do some testing in Walmart that day. So we're excited about that partnership. And so that is HIV pre-exposure prophylaxis. And now you as Board of Health members are in the know about HIV in our county, what can be done. So I just need you guys to say, yeah, we can go ahead and do this. Any questions?
This is the program we agreed on before.
Yeah,
It's
it's
the same
already
one.
been approved.
Yeah, we
I
already.
just wanted, because there were new members, and I just think you need to know as Board of Health members that this is very important for our county. And I have gotten a few surveys back, and one was very interesting. And the person that answered it said that they would use the PrEP clinic, and that there's a population in this county that we don't realize have a need for this program. And so we have to put all our prejudices and our judgments aside, because as a nurse, I take care of people, and that's all I know. I really don't care about the money. I know I'm supposed to, but I didn't go into nursing to make money necessarily. I went into nursing because I cared about people. And so to treat a person is to treat a person. And if it helps save lives, which it will, I think it's an important program to have. So that's all. Questions?
So when is, like, since it's already approved, when is like your expectation that you could have it up and like ready to roll out?
I hope by the fall, because we'll have to advertise. And of course we have an HIV population that have partners, and and people that they know in that community. So it's a matter of getting it out there that we're going to do it and doing it really. And if we can get, if I mean, the largest amount that Walmart could give us would be $5,000. And if that goes a long way when you talk about $80 a person for a year. So we could stretch it out a little bit, but that won't last forever. So eventually, if this program takes off and is beneficial, we will probably need to talk about it later down the road as far as budgeting and those kind of things. So that's another reason I wanted you guys to know about it.
So right now you got enough to start it and roll out in the fall.
Hopefully if Walmart gives us a big check. So yeah, but they've been great. And so we're excited about that.
Let's say they give you a little check.
I don't know, BJ, we're going to have to, Commissioner Gibson, we're going to have to pray on that one's what I've been doing a lot. And again, I do hope there's some federal funding that'll come out. If not, then we may have to go to the commissioners and ask for some money.
And you already have your target, like you already have the people. that you're gonna-
Identify.
Mhm.
For the person that could use it for your first rollout.
I think it would start slow, just like the HIV clinic did when we started it, and it's a lot of word of mouth. And again, that stigma's there. So some people won't, jump into it real quick. But I was a high school nurse before Nicole started there, and she came in behind me. And I can say from experience that I've seen someone who should have had this program and should have been on these meds go from not being HIV positive to being HIV positive because it wasn't there.
So you think this would be something that would be good to partner with the two committees that came for the teen pregnancy?
It's STD prevention. I mean, it's an STD. Yeah. And look at the age, look at the demographics. Yeah.
As pediatricians,
And it's-
I know that our young
uh-huh,
people, they're doing
yeah.
stuff that sometimes they don't want to admit to, but
Yeah.
they're doing it. So
And I don't know, there was a show that used to be on called Scared Straight, but I don't know how you can really put that image in somebody's mind that's never seen someone with AIDS. And there's just a population now that take a pill, it'll be okay. It'll be all right. But it's not.
You say you've gotten results from the survey, so that means the
Mhm.
survey is out
Mhm.
somewhere. for
It is.
somebody to look at.
We've put it on
Good.
Facebook, and I have, we're giving it to our HIV patients to complete. And there's a little poster when you come in the health department with the scan code on it. Put it in the bathrooms at the health department. And so it's out there already for people to answer. Mhm. Yes, Mr. Rayleigh.
I noticed, part of the presentation was that the poorer counties had more than prosperous counties, but I'm looking at Jefferson County and Coleman County in Alabama. And Jefferson County is a very prosperous county, and it's black. And Coleman County is almost white. I'm talking about the color on
The map color.
and it's a rural county. People in Alabama just different or what?
I have no idea. I don't know about Alabama. I only know what we have here. It's based on per 100,000. So you got to think about that too. Smaller your population. I mean, for every HIV or AIDS case we have, it's tripled because we have 34,000 people.
And I see that our western county is in pretty good shape. And those are mountain counties where poverty is
Mhm.
the rule, there's an exception.
And I do believe that COVID, because they're saying now you really can't trust the 2020 data because there was so many other things going on, and were ignored, for a lack of a better word, during COVID. And so I keep waiting for it to come out of the woodwork, with the after effects of COVID and the population that missed sex education and now they're of reproductive and sexual age. And yeah, we've got some work to do as public health. We were built for prevention. You know, we focus on, we don't do primary care because that's not what public health is. We're a prevention agency, and we prevent STDs, and we try to prevent diseases like with animal control and environmental health and your well water and safe drinking. Is all about prevention when you talk about public health. And so for me, PrEP is exactly what public health is supposed to be doing.
And what do you want us to do?
Just to be in the know, and I don't know if it needs to be approved again since it was once before, but
Ms. Dollar, do we get any Ryan White Foundation funding?
with our HIV program that we're subcontracted with Robinson County Health Department, it is Ryan White funds. But Ryan White funds are not available for PrEP.
So this would not open the door to increase it.
Mm-mm.
Approximately how much are we getting there?
We were.
It's 30,000 a year, and that
Us 15, and we burned right through it with our HIV clinic. So they extended it to 30,000 this year.
yeah, we actually we ran out of money for our HIV clinic last year, and luckily they were generous enough to recognize that we had that need, and we could take more patients if we need to take them in our HIV clinic. And I believe public health does things better than most places do when it comes to things like this. And so, yeah, but so I don't know if you think they need to approve it again, Nicole?
No,
Okay.
it's been approved
Okay.
already.
All right.
You got my support. Anything to prevent it, because
Okay.
then that'll prevent the money from the HIV clinic running out.
Okay.
So
Okay. Well,
I
that's
just want to
it.
know when you get that check.
I know.
Check.
I know. The big check.
The big check.
Thank you.
Next on the agenda is the child fatality report. Ms. Kalata.
Okay, good evening. I am Carlotta Rivers, and I am the maternal health coordinator at Scotland County Health Department. One of my additional job duties includes being the chairperson for our child fatality prevention team. So because I know some of you are new to the Board of Health and you may be familiar with it, but I just wanted to give a brief overview of what our team is and how we work in conjunction with the Community Child Protection Team. So as an overview, a statewide multidisciplinary, multi-agency child fatality prevention system was developed starting in the 1990s, and it consisted of the North Carolina Child Fatality Prevention Team, the North Carolina Child Fatality Task Force, and including our local teams. Each county in North Carolina has both of the Child Fatality Prevention Team, which I will refer to as CFPT, in conjunction with the Community Child Protection Team, known as CCPT. And the purpose of this system is to assess records of selected cases of children being served by Child Protective Services and the records of all deaths of children in North Carolina from birth to age 17 in order to develop a community-wide approach to the problem of child abuse and neglect, understand the causes of child deaths, and also to identify any gaps or deficiencies that may exist in the delivery of services to children and their families by public or private agencies that are designed to prevent future child abuse, neglect, or death, and just to give basically children and their families the services that they need. So the Community Child Protection Team, or CCPT, was established in 1991 to review selected active cases of child abuse and neglect and cases in which a child died as a result of suspected abuse and neglect. And the local child fatality prevention team were established in 1993 to review all additional child fatalities and make recommendations to state policymakers. So the Scotland County CFPT is again, it is a multidisciplinary team. So as you can see, we have members from the health department. We have a review coordinator. That is Miss Deborah Rogers, and she has somewhat been, she has filled in since the last person went to a different agency in the county. And Miss Christine Russell is going to be the incoming review coordinator. And we have health department social workers, the DSS director, board members, our health director or designee, which is myself. I am the chairperson. And we also have Miss Joy Hawkins, and she is the incoming co-chairperson. District attorney's office, we have our provider, our family nurse practitioner at the health department, and others. And if you'll see on the PowerPoint slide, we have 16 positions that serve on both the CFPT and also the CCPT. And in addition to that, out of those 16 positions, there's a combined one with the medical examiner and EMS, which is held by Robert over at EMS. So the Board of County Commissioners can also appoint an additional 5 members, and those are asterisk in blue. We do have a parent, and that parent is a parent of a child who passed away before their 18th birthday. So this is our team. So our duties, we meet 5 times a year. The state mandates that we meet 4 times a year, but we throw in an extra meeting in case there are additional cases between the joint team and we can get those reviews done. And we discuss the child fatality cases from those who are less than 18 years of age. And again, we try to identify if there were any gaps or deficiencies or system problems that may have contributed in some form to those children demises. These cases, after they're reviewed, if there are recommendations made by the team, we note those, and those are sent to the local review coordinator, to the state coordinator. And during every local meeting, each member is asked to review information from their representative agency relative to the case and present it to the group for discussion. If any recommendations are made, they are forwarded to Carrie Young, who is our state CFPT coordinator, and she started last year in April of 2022. From that point, it is sent to the North Carolina Child Fatality Task Force. And that group is basically the legislative piece of the child fatality prevention system. So they come up with ideas from the local teams, filtered to the state coordinator, and then anything that they want to present and make a law, that is the purpose of the North Carolina Child Fatality Task Force. So looking at Scotland County's joint team, we reviewed 7 cases, and this lists the causes of death. So I'll just go through them briefly. And just so you'll know, the information that we discuss during these meetings are confidential. So you may have questions regarding circumstances. We can't answer those because it's confidential. We can't share that outside of the meeting, but we can share with you the causes of death and the age of those children. So there was one due to acute myeloid leukemia. That child was 16 years old. There was drowning in a pool. That child was 21 months old. Gastrointestinal infection, which was specifically necrotizing enterocolitis. And that baby was 1.5 months old and was born premature at 23 weeks. We have 1 homicide by firearms discharge of a 17-year-old, 2 other ill-defined and unspecified unknown cause of mortality, a 2-month-old and a 7-month-old, and then we have 1 undetermined of a 4-month-old. So our recommendations pretty much, we didn't find any gaps in services or system delivery problems. But however, we started a Safe Sleep campaign in this county all the way back in 2012 when I first joined the team. And we sought to address the safe sleep education, because that has, although it has gotten better in this county, it continues to be an ongoing problem, not in Scotland County, but including our surrounding counties. And so we work together between the health department and the different departments within the health department, from our maternal health clinic, our OB care management case services, also at Scott Memorial Hospital, to discuss safe sleep measures so that we're all on the same page and that we're communicating the same information, because we're all serving the same population when it comes to prenatal patients and their families and their babies. And one recommendation that I made as a general recommendation is to monitor the number of cases where the parent or the caregiver is known to be under the influence of drugs or alcohol. I sat in on a webinar that was presented by the state CFPT. And it's a new term, and you'll probably hear more about it, but it's relevant to safe sleep, and it's called impaired sleep. So that's when a parent or a caregiver taking care of a child, especially under the age of a year, are using substances that may cause them not to be able to be fully present and observant of that child. And it can include substances, whether prescription or non-prescription, or illegal substances, and including alcohol. And it alters their judgment when it comes to taking care of a child. So that's something I'll be monitoring in the cases that we review henceforth. And our activities for 2022, again, we met 5 times. We had no subcommittee meetings. Scotland County, of course, we are a small rural county. So counties who are bigger, such as Mecklenburg or Wake, they have so many case reviews, they can't get it all in the 5 times. So they may develop subcommittees to review additional cases. In the past, we've used our subcommittee for our outreach projects, but we haven't had any of those recently. The CFPT chairperson, which is myself, reviewed the report to the Scotland County Board of Health on June 21st of 2022, which was last year. And then that was co-presented with April Sneed, who is the Scotland County DSS Director, in May of 2022. The 2022 annual summer activity was submitted to the state coordinator in June of 2022 as well. So I wanted to show you the infant mortality rates of Scotland County in comparison to North Carolina. And of course, Scotland County's average is higher than North Carolina. And we have pretty much been higher than the state average every year except for 2018 and 2019. The previous chairperson for the Board of Health had asked for a comparison to a bordering county, so I selected Richmond because we're probably more comparable in size and population in Richmond, and their infant mortality rates have been higher than ours more consistently, except for 2018. Any questions? I did want to make a point. I did include 2 documents for you. Joy and myself, we attended a state child fatality prevention team meeting back in March. And one thing that was discussed is they're looking at overhauling the complete child fatality prevention team system in North Carolina. Apparently, they had it reviewed, and what was told to us by representatives on that day is that North Carolina has one of the most decentralized child fatality prevention systems in the United States. It's complicated, and the cases are being reviewed by multiple groups. So they're looking at trying to overhaul that to make the system better and preferentially more efficient. And On this action agenda, it's called 2023 Action Agenda. You can see some of the legislative recommendations that they are going to be presenting. I won't go through all of them, but I wanted to make sure that I include these so that you can see the things that we do on a local level do make a difference, because we do filter those up to the state and then they send them to the legislative body. Okay. Thank you.
Thank you, Ms. Carlotta. Next on the agenda is informal discussion, and Ms. Sharon wanted me to remind everyone that hasn't did the Board of Health training to complete that. That was a reminder to myself too, because I need to go in there and complete that. And it's also, you should have a gray sheet, the environmental health agency permitting process. And this is just to remind everyone that if you're a vendor in Scotland County for events, you have to have a permit. That's it, right?
And
That was
supposed to go with my fee schedule presentation.
this,
Yes.
No, this is something different.
the
Yeah, this is something
environmental health.
different. As Board of Health members, you may get a lot of questions about how to permit for temporary food establishments, because we get that a lot. And Valentina did a presentation, I think it was last year. So now's the time, the summer months and fall months is when we see a lot of events happening. So she just wanted to make sure everybody had that in hand with the policy and procedures in case somebody would happen to ask you as a Board of Health member, what is the procedure, you would know. What's the requirement?
So it's like festivals on the street, in the park. Okay.
Madam Chair and Health Director and Ms. Sharon, there are some North Carolina Association Board of Health and National Association Board of Health trainings that are held for Board of Health members. I would that you all look into some of those annual trainings and bring that information back. Virtual is good. I mean, getting on there, running through, but there's so much that we can
Is it in
learn
person?
attending some of those in-person training on the national and state level. That I think would be a benefit to board members as well. If you all will look into out for some of the information I've received from North Carolina Association County Commissioners on that as well. But I think there'll be some benefit to attending some of those trainings. I've had to work with Miss Valentina quite often with some of these festivals and getting these people certified. And I've shared this with her, and I want to say it publicly because it's been said to me. I think it's important that we continue to share this information so that people are aware, because it can be quite cumbersome, and that we're consistent in doing it. And I know Ms. Valentina is. I mean, she's going to do it to everybody. But that's always a concern that's shared with me. If we're doing it at this festival, are we also doing it at that festival? I know that we are, but I think we have to make that known publicly so that people don't feel like we're picking and choosing who we mandate this for. So thank you.
All right. Next on the agenda, we'll go into closed session. I have to read this whole paragraph, don't share the whole paragraph. We're going into closed session to consider the qualification, competence, performance, character, fitness, conditions of appointment, or conditions of initial employment of an individual public officer or employee or prospective public officer or employee, or to hear and investigate a complaint, charge, or grievance by or against an individual public officer or employee per General Statute 143-318, 11A6. We want to thank everyone for attending. We want to ask everyone to leave except for the board members. Thank you and good night.
And I just wanted to remind everybody, there's food over here.
Oh,
There's
your food.
also t-shirts for those